we observed an outlier in the population. And I think it's similar to inborn errors of metabolism. It's always the outliers which are the interesting one, because like in inborn errors of metabolism, by identifying the defect, we can understand, the principal mechanism. And the same applies to pharmacogenomics or so.
But I was puzzled a little bit by your explanation regarding randomized trials. And I wanted you to explain what you said for those who didn't hear you, and to ask you, don't you think that trials on guided on genetic testing should be done to show that this can be a good way of having the conclusive answer in terms of relevance of pharmacogenetic, for example, for warfarin or for clopidogrel, or if these drugs are still very much used. It's not the same when a drug is replaced by newer ones or more relevant ones. But what about those who are still undertaken by many patients? Shouldn't we try to realize randomized trials guided on genotyping?
Yeah, it all depends what the purpose of your study. I think if you say, okay, we use genotyping for genotype drug dosing, I don't think you need a randomized prospective trial. Let me explain in such a way. You don't need randomized clinical trials to prove dose adjustment in renal disease, in liver disease. And if you look in the guidance, in the label of the drug, it says you should adjust the dose according to the impairment of liver function. How you assess liver function. If you look, they are rather vague about this. I would say, so if we say, okay, or let us take the case of drug-drug interaction. Usually, it's going to happen in the following way. You identify a patient who has a drug interaction. Then you look what happened in this patient. You see high drug concentrations. Then you go back, and that's what the regulatory agency is required, doing a study in a limited number of healthy volunteers. See if this drug interaction increases systemic drug exposure. And based on this limited number of studies carried out in healthy volunteers, you do a labeling and saying, oh, okay, this interaction occurred, and you should reduce the dose or avoid it.
But do you agree with that?
No,
because you may think that sometimes you have some PK/PD changes, but which is not necessarily relevant in terms of clinical efficacy, for example, of a drug. I think, again, it's different when you're looking to the toxicity of a drug, but when you're looking to its efficacy.
The other one, these dose recommendations are usually based on the concept of systemic drug exposure. And this goes back, of course, the way drugs are developed. So you start in a phase 1 study, with 1% of the dose, which causes toxicity in animal space. And then you escalate the dose until you get side effects. And that's the limiting thing, which clearly indicate first that a dose dependency and also an exposure dependency. And I think it's underlying, and this is underlying the concept of saying, if you see in the older population an increase in the AUC by a factor of 2, this is considered to be relevant. relevant, and then you say you reduce the dose, and the notion underlying this is that higher drug exposure correlates with an increase in side effects. That's the assumption.
So for you, we shouldn't try to do randomized trials guide on according to genotyping in order to see the efficacy of a drug or clinical response.
You should do these dosing studies in your targeted patient population. So, supplement the genotyping with measurement of drug and drug metabolite, in the case of active drug metabolite measurement. And then, you get also the information how comorbidities influence and how co-administration of other drug influences.
But if I challenge you, and coming back to clopidogrel, for example, if you do PKPD in patients with peripheral arterial disease, and you look to the dosage, and you look to the genotype, you would see changes and differences. And yet you won't see, as you mentioned yourself, a difference in terms of clinical response according to the genotype. So I think we have to be careful about the conclusion of PKPD changes with different doses in terms of clinical response of a drug.
No, I think, first thing is, we go back into clinical practice. I think, how often is dose adjusted in patients with liver disease or renal function? I think not taking into consideration, for instance, in the elderly population, the decrease in renal function is quite often a reason, why elderly patients develop toxicity or side effects. So, and I think it's not different from a polymorphism also, yeah? I think it's the negligence by the treating physician of basic principles, which causes the problem. I think one thing is dosing. So what you can do is by genotyping, if you have, for instance, and you happen to be a poor metabolizer, and there's a 20-fold difference in exposure, and you identify right from the beginning, you adjust the dose. So the likelihood that he will have concentration-related side effect is being reduced. The other thing is, of course, that's a different story, is how a genotype relates to clinical outcome. Mm-hmm. Yeah? And my former boss, Hans Stengler, used to say, there's something like intelligent non-compliance of the patients. They realize, at the dose, the doctor, I don't tolerate this. So either they reduce the dose or they throw the drug out of the window. The basic concept is we got a pro-drug, yeah? And, this is being questioned by the community, but I think there's good evidence that most of the effect which you see is via these metabolites, the active metabolite. Mm-hmm. That's one thing. The other thing is, based on this, you could anticipate if you form less metabolite, that due to a genetic defect in the formation of this active metabolite, the clinical outcome might be poorer than opposed with patients who have a normal activity. And I think the problem, which I see with tamoxifen, is that the studies which tried to replicate the initial finding by Matt Goetz and Jim Engel from the Mayo group, were poorly designed and executed. And as I tried to explain, there are many things which can go wrong. But I think this is not only restricted to pharmacogenetic association studies. You will have it in every area. The problem is, methodology. First of all, the number of subjects or patients required, a number of events, and so on. And in the case of tamoxifen, I think it was genotyping, and then of course, the problems of using DNA from the tumor as a source for genotyping,
rather than
neglecting the loss of heterozygosity. And I think the first thing you do is, if you ever do a genetic study and an association, you test for Hardy-Weinberg equilibrium, which was not done in the big 98-1 study or so. That's the first thing. In the case of tamoxifen, if you want really take into consideration the complexities, gene interactions, that is, in addition to 2D6, 2C9, 2C19, 3A4 is involved, and so on. And if you want to stratify and develop a model, how you should dose and so on, incorporate the genotype, you would need at least 8 to 10,000 patients. Now compare this with the number of subjects recruited in the different studies. They will see, right from the beginning, it's hopeless. You can predict it's going to fail. And I have to admit that our initial study involved only 300 patients on this, and it turned out to be positive, but in retrospect, to admit it was underpowered. And that was the reason why we started the second study published in the JAMA in 2009 or so, joining data from different groups where patients had been collected by the same criteria with respect to estrogen receptor status and so on, and nodal status, and completeness of allele coverage. I think we had the problem. I was involved in the so-called International Tamoxifen Pharmacogenomics Consortium, where we tried to set up a sample worldwide, putting together all the data. And right from the beginning, we said, allele coverage should include at least 5 variants and should have this clinical characteristic and this characteristic. Besides this, data were submitted which did not fulfill this criteria. So 5,000 patients were recruited, and finally we could use 1,900 patients. So on average, the complete cohort didn't show a correlation between genotype and outcome. But if you restrict the analysis to the initial inclusion criteria, it turned out to be significant. So this is why I appeal, join forces. And I think funding body should acknowledge, if you form a consortium, that this is really contributing. I think the other example is extreme or rare adverse drug reactions, like Stephen Johnson, or toxic epidermolysis or so. It occurs in 1 in a million patients. So if we want to understand the underlying mechanisms, and the data indicate that there's a strong genetic component, not a single country will ever collect enough patients. So this needs an international collaborative effort. Europe, US. Despite this, you've got also ethnic differences and so on. And I think we have to think about, in our funding bodies about, ways and means to stimulate this and support this, and also, collecting data from a patient, getting DNA. Maybe it's not intellectual challenging, but without this, and having good phenotypes, without you can.
Idea of personalizing medicine is something that interests all the physicians who takes in charge patients. And there are two different questions. One is how to individualize therapy in terms of efficacy, and the other one is how to avoid safety issues with drugs by personalizing the dose and or changing the drugs, etc. So pharmacogenetic in that issue again has also its interest, and we have to be very careful about who we are studying, which phenotype, which population, with which risk, because sometimes obviously we may accept some risk when people are at high risk of an event, and you would accept to go for a efficient drug with a higher toxicity, where in another population it would be just unethical. And I was very interested to hear what you were saying, Professor Eichelbaum, in terms of pitfalls that we have to be aware of when we are studying pharmacogenetics.
The other example is extreme or rare adverse drug reactions, like Stephen Johnson, or toxic epidermolysis or so, yeah? That there's a strong genetic component. Not a single country will ever collect enough patients. So this needs an international collaborative effort. Europe, US, despite this, you've got also ethnic differences and so on. And I think we have to think about in our funding bodies about, ways and means to stimulate this and support this, and also, collecting data from a patient, getting DNA. Maybe it's not intellectual challenging, but without this, and having good phenotypes. So I think you also, the best molecular biology won't help you if you don't have the patient and a clear-cut definition of the clinical phenotype and outcome. I think we are focused in medical education on diagnosis and pathophysiology. So it goes back into the 20s, this what we call the Vienna School of Medicine, and saying the diagnosis means everything, not paying attention to therapy. So this might have been correct at that time, but in the meantime we have developed many powerful drugs. Everybody is allowed to prescribe a drug. We assume that the doctor understands everything. But I think in contrast to diagnostic procedures which are carried out by specialists, there might be patients who are harmed, but the chances to be harmed during diagnostic procedure is much less than going home and getting a prescription for that. Should be, to me, an essential part of medical education and also medical practice, to understand that.
Thank you.